Thank you, Ramya, for reminding that I had forgotten to record the session. Yeah, so as I was saying, that handing over is considered Bermuda Triangle of healthcare, and most of the lapses happen because of poor handing over. I'm sure those of you who are into management, you must be facing this challenge day in, day out, where people, though they hand over, but they don't hand over. And in real sense, it actually leads to a lot of problems. So if you may share just one or two of the experiences where people did hand over, but actually the handover did not happen, and you all had to face the consequences of it. If you can recollect any incident. I think Dr. Gaurang has raised his hand, so he has experience to share with us. Go ahead, please. Yeah, Dr. Gaurang.
Yeah, so what happened, ma'am? One of my colleagues, so we always had two interns following up each case. So because we had 2 units, one unit to the other unit, so there would be some discrepancy. So what happened during admission day, a set of interns would admit a case. They would write the orders because they've evaluated a child. So for pneumonia, we had this exact case. So it all depends on the categorization. We have different plans of treatment. So based on the category of pneumonia, we start antibiotic or we don't start antibiotic if it's viral. So this baby had bacterial pneumonia. So what has happened is the previous intern had written all the orders, but had mentioned about the use of antibiotic at the last line somewhere in the corner. Well, in the case, had they mentioned the type of pneumonia, or when you're writing in the case sheet, you had made specific descriptions of the type of pneumonia and not realized it, probably the next intern who followed up would have started the antibiotic on time. The child did not show any improvement, and only on day 4 post-admission, we realized that the child did not even have an IV line started and there was no antibiotic given to this child. So basic writing and the way you write, because sometimes what happens is in the fix of time, when we hand over, we say orders are written, you see. But when you actually see the orders, like repeat all orders. Is the orders nobody takes the pain and initiative to enlist the orders that have been told by the consultant or written by the previous intern. Repeat all, repeat all, repeat all. So we also write repeat all, and the sister only sees the last repeat all. And when the consultant would have added something in the end, or you would have marked something in the end, which you failed to recheck the next day, this issue continues. So there are 2 things from that which I learned is, whenever you're handing over a case, ensure that you write the diagnosis in complete sense in bold form, so that even if you miss communication, the other person knows. Second, from that day, though it happened to 2 of my colleagues, that lesson that I learned is never write repeat all. It's okay if you take 3 minutes of your extra time, sit down and write those 10 orders separately, including the day of admission and the date of the application of the drug. Just don't write repeat all, because it's going to cause trouble somewhere.
I think, Dr. Gaurang, you have not only pointed to one concern, but multiple concerns. So one is, do we really know how to write about patient's treatment in the right order? So usually we should write the medicines first and then other things later. That is one thing, so that immediately you get to realize. And second thing is, just documenting is not enough. I think communicating and getting that done is equally important. So a lot of time we would write, but we would not communicate. The next person may not think of reading the notes unless you say, okay, please start antibiotic. I've written everything in the documentation. So and then the proper way of handing over, and see, 4 days the patient is with me, and if I know the patient should have been on antibiotics, and very clearly you said the patient was not even given IV to start with, that itself should have immediately warned the doctors and the nurses that what are we doing by just having the patient here? If you're not treating the patient, then why is the patient here? And the patient will definitely not improve. So it's a very sick, very clearly visible mistake, but then it happens right under our nose. And these things are so often, healthcare industry is considered more dangerous than aviation industry and nuclear industry. 1:33,000 errors. We have 33,000 errors in healthcare, then we can think of 1 error in aviation industry. So just yesterday when I was trying to, read about the errors in aviation, I could see sparingly 2013, then 2016, 2018, like whatever happened in terms of their decision, and that led to crash of the airplane or something of that sort. But then not like every day or every minute. But imagine the state of affairs in healthcare. And not that we are less intelligent than them, because we are less organized than them. We are less system oriented than them. We have always done medicine practice as person oriented. So that was okay when there was one single doctor working in a clinic and he had one compounder and a nurse, and there used to be OPD and simple set of medicines like antibiotics and then some anti-inflammatory. It was okay even if we didn't have any system. But today, healthcare delivery system has become so complex, it's impossible. I was reading this book by Atul Gawande. I'm sure some of you may have read it or you may be reading it. So in ICU, he said one of these set of engineers, they studied for a patient in a 24 hours, we do 178 interventions per patient. 178 interventions. So tell me, how is it possible for anybody to remember whether I did or not, whether I did it right or not, unless we have a habit of actually recording it and doing it in a systematic manner? This book is worth reading. I'll say everybody to read who wants to, work in healthcare. This is going to be like a wonderful, it'll give you a wonderful insight. And this coming from a doctor that we are making so many mistakes is such a humble submission that we are human beings and humans are fallible. We need to have system where we have, process in place. Even if there is an error, it can be, controlled and stopped or checked. Yeah, Dr. Iti, good that you have read it and you found it good. I'm glad. And I have read it so many times, and every time I read, I get something new to talk about. That's the idea. Yeah, Dr. Rami, I think you also want to share some incident. Do you have something to share?
Yes, madam. Actually, it was about like when I was working in an ICU, I was working as an intensive nurse. So usually we have 2 to 7 shift. Like afternoon shift will start from 2 and finish at 7, and then the next evening shift, that is night shift, will start from 8 p.m. So usually what happens is everybody wants to go faster to their houses. So at 6:30, my in charge will go inside, she will dress up and come back. So mostly when we take the handover, already they will be in the normal dress and they will be giving us a handover. So and that time we were the most junior nurses were in the in the ICU ward. So then there will be 7 patients in ICU, and one will be given to each of us. So we were just taking the handover. I used to go with each and everyone because I have to help all the 6 nurses over there. So suddenly our intensivist husband, he's an echocardiologist. So he entered the ICU and he said, "Who is the patient? I have to take the echo." We have not yet taken the handover, nothing we know, and we know that person is very difficult to handle also. So he turned here and there. I said, "Sir, I do not know whose echo you have to take, plus just give me some time." And he walked out. And he chale gaya. Then we find out that the first bed child has to be done. And then after so many sorries and all those things, he came next day. Then he saw that the child is having pulmonary hypertension. And then we have to do something intervention, but still we were not able to help that child. So
Wow.
I feel that there are many factors which has been there in just having a problem with the child, and he could not save that child. It was the ego of the doctor. It was the timing. And then he should have also taken some time. What is happening? I don't know what he was going to do with that 15-20 minutes. We were not able to answer him. So I felt very bad. And that time I said, I should be, at least in my life, I should not be like that. You should not have the ego. You should give respect to each and every one of your team member. So that
Again, I think you have picked up very important points. You have picked up very important points. One is, of course, the hierarchy, where we have this, somebody comes with the ego that, okay, I'm the boss and I'm the one who's going to dictate. At the same time, I think the point that you have pointed, that 2 to 7 and 8 to next day 8, for example. What about 7 to 8? Where do patients go? And in case in those hours, if patient has some cardiac arrest or some bleeding or severe pain, who will attend? And if you're not in uniform, how do I know that who's my nurse who's going to attend to me? I mean, this is a very big problem. I'll be discussing this as one of the reasons for failure of handoff. I'll be talking about it. But I think what you have said is absolutely, out and open. That, okay, we are calling for problem and we are ready for problem. That's what I can see from the example that you have shared with me. So Dr. Ila, do you also have any incident to share?
Yeah, very small incidents. If we have time, I can share. Patient went under a craniotomy at 2 o'clock in the night. And then the drain was put up by the neurosurgeon. Patient was shifted from OT to ICU. And in the OT, when the drain was put up, it was kept closed. And then it was supposed to be given as an over. And over from OT to ICU, that drain has to be opened up in the place where the patient is at the bedside. And the over was not given, the drain was not opened, and it was a havoc. By 9 o'clock in the morning, the BP rose. I mean, the pinpoint pupil, the whole craniotomy which was done was at toss.
Oh God.
And then 9 o'clock, and then immediately when the doctor on duty came, and then he saw why it is like this and all, and then they saw the drain is not open. And the drain was put on. Luckily, the patient survived later after that. Immediately 150 ml of drain was, out when we opened the drain. So the handover is so important. I just wanted to share that.
Oh my goodness. So it clearly shows when we are not handing over properly, how that can lead to delay in treatment, that can lead to wrong treatment, that can even cost us patient's life when we don't hand over properly, and it can be, so very risky. I think Dr. Dipti, when you have something to share, maybe when I start the discussion, if you can in between talk about your case, will that be okay? Because I have yet not begun the session. We are just discussing the topic of poor handing over. So is it okay?
So this is something which I had it very, very serious, and today also I was with my HOD, and on it it was too awful. So that is why I'll share.
Okay, you can share it. I think even that's a big learning for all of us. Go ahead.
Just take 1 minute. This was a lady who came with eclampsia to us. So eclampsia, we give magnesium sulfate IV loading dose, 4 grams. So in casualty, she received from my gynae casualty 4 gram IV. And the labor room is just next door to it. They are connected. She goes to labor room, and the SR, without seeing that she has already received, and the first year PG writes on 4 gram, and that lady receives 4 gram again. She immediately becomes, within half an hour, the patient is drowsy, unconscious. She has to be intubated and shifted to the ICU.
Oh my
of course, when I was told, the only thing I suspected was that she has got wrong dose.
Double dose,
so I immediately had my consultant check, but they said the dose was all right. It was a few days later that we went back and noted small writings. They're all nibbled in bad handwriting. Somebody has written, somebody has checked that she has received it twice. Now she could have just died. She could have just died. And it is so serious. I talked to my HOD. So the HOD is, she's a very nice lady, and she says, blame game nahi hona chahiye. I said, I don't, blame has to be there. No, how we do give blame? This woman will die and we keep on wrapping that blame game nahi hona chahiye. I am at a loss as to how to handle such situation. While
Dr. I would again say, please start implementing CAPA in your system. See, there will be errors. Unless people are trained, they will make errors. But you have to find ways to prevent those errors. If you had a kind of a chart, standardized chart for every pregnant woman coming to your emergency, and if you put that chart on the case sheet, on the top of the case sheet, and you write those things that are usually done, when they are done, a tick mark and signed by somebody, person can look at it, yes, done already.
But
I think this is not the platform to discuss all those things. My heart goes for that patient that we could have lost a life.
She's safe now. She came back and she has survived.
But that's her good luck. That's her good luck. I believe that she got saved. We had killed her.
I've got 100 of clinical situations, and I've got nearly 100 residents who are coming and going. There's a constant flux. I am at a loss.
That is what I'm saying. If you will have systems in place, even 1,000 people come and go, your working will not get affected. The point I'm trying to make is we are making it person-oriented.
I'm telling you, my whole faculty is not tuned to know what having a system in place means.
Your residents are under your control. Dr. Dipti, I think we'll be digressing from the issue if we will discuss this thing. But remember, you may not have control on your higher ups. You have all the control on your residents. And that's the beauty of your working. If you will start doing something, and if people will see positive changes and results, they'll slowly start following you. Initially, people will always oppose you. Remember this, be ready for it. Any change, people will oppose it. Be ready for that, but continue with the mindset that I want to bring some change and some positive change in the system. I think I'll end the discussion here, because though I know this is such an important topic, and you may find my topic as a very, theoretical, not theoretical, but then of course meaningful. But we have to go on with the topic, and we have already crossed 30 minutes. Monica, I'm sorry, I will not be able to give you a chance right now, but maybe in between you can bring in your case, whatever you want to discuss. Is that okay, Monica?
Yeah, absolutely.
Thank you for understanding. Yeah, and see, I opened the Pandora box by just by asking you, tell me the errors that you see happening under your nose every day, and we are not able to do anything. At least we don't know where to go. But of course, there are ways. There are management protocols. Please start using those protocols to make things better. Okay, I end the discussion here. So patient handoff is a very, very big challenge. I wanted to do an activity. I'll be sending 5 of you outside once again, and we'll call you back in a minute. Give me a second to send 5 of you. So Banu, I'm sending you, I'm not choosing anybody. The first name that comes in the list, I'm sending. So Banu, I'm sending you to the waiting area. Are you there, Banu? Banu Rekha, are you there?
Yeah, I'm there, ma'am.
Okay, I'm sending you to the waiting room. Okay. Dr. Dipti, I'm sending you to the waiting room because your name is second. Then Dr. Ela, I'm sending you. Okay. And then I'm sending Monica. And then Pooja. Okay. 1 second. Fine. So I'm going to show you a slide, and Namrata, I'm going to show you this slide. Okay, I think instead of Namrata, I should be showing to somebody who is well versed with healthcare. Namrata, are you well versed with healthcare?
Yes, ma'am. Yes, ma'am.
Okay, fine. So I'm going to show you a slide, and you have to read it to yourself. Everybody else will be able to see, but you need to just read it for yourself. Okay.
Yeah, should I start, ma'am?
No, you don't have to read it loud, just read it to yourself.
Okay.
So imagine that you are a nurse or a doctor, and this is the handoff you're going to give to your next nurse or a next doctor. Tell me when you're ready.
Okay, ma'am.
Okay, 1 second. Okay, so I'm going to enter one person from the waiting room. So imagine that you are the nurse on duty or doctor on duty, and you are handing over this to the next nurse. Give me 1 second to get them in. So I'm getting Dr. Monica.
Yes.
So Dr. Monica, imagine that you are a resident, and Namrata is also a resident, and she's signing off. She's handing over this patient to you, and she's giving you a set of information about the patient. So Monica, please go. Namrata, go ahead, please.
Yeah. Hi, Dr. Monica. So today there is this patient. He's a young 14 years old boy who came
Just
with.
1 second, hold on, Namrata. All others, please keep noting down the observation of the discussion. Write in the chat box, but don't click it till I say I want feedback from all of you. But you can keep writing in the chat box so that you don't have to do it double the time. Yes, Namrata, please go ahead.
Yeah, hi, Dr. Monica. So there's a handover for today. This young boy is 14 years old, and he came with acute asthma due to URI. So he is all well, he's improving, he's going home most probably tomorrow. So he's still on oxygen actually, but you'll have to wean it, like weaning has to be done throughout night so that tomorrow morning he's Like he's supposed to be discharged tomorrow morning, so he's all ready to go home without oxygen.
So Dr. Monica, is that okay?
Yes, ma'am.
So I'm admitting Pooja, and you have to share this information to Pooja, assuming that she is the next resident on duty and you are handing over this patient to Pooja. So let her join once. Yeah. Pooja, imagine that you are the next resident on duty and you have come to the ward. Dr. Monica is the resident who is signing off, and she's handing over this patient to you. So Monica, please go ahead and share the information with Pooja.
Okay, so hi, Dr. Pooja, good evening. So we have a 14-year-old boy. He's
sorry, your voice was a bit breaking. Can you just start repeating? Sorry, Monica.
Okay, yeah. Can you hear me now?
Yeah, it is clear now.
Okay, so we have a 14-year-old boy. He's suffering from acute asthma with upper respiratory tract infection, and he is supposed to go home tomorrow. Currently, he is on oxygen therapy, but we'll have to wean him throughout the night, and so that he's able to go home comfortably tomorrow. Did you get me?
Yeah, you can repeat it once, please. It was a bit fast. Sorry.
Okay, ma'am, do we have to repeat, or we'll have
to? It's okay. In case if she's asking to repeat, it's okay. You can ask. You can always repeat.
So we have a 14-year-old boy. His diagnosis is acute asthma. He's suffering from upper respiratory tract infection, and tomorrow he's getting better, and tomorrow he's going to get discharged. Right now he's on oxygen therapy, but we'll have to wean him through the night so that he's able to go home comfortably tomorrow.
Right.
So is that okay, Pooja?
Yeah, ma'am.
So I am admitting the next person, that is Bhanu Rekha. You have to imagine that she's the next resident who's joining in, and you have to hand over this patient to Bhanu Rekha.
Right.
Let her come in. I'll just brief her and then you can start speaking.
Right.
Bhanu Rekha, are you there? Bhanu Rekha, are you there? Bhanu Rekha, are you there? Okay, I'm admitting Dr. Dipti. Whatever information you have received, please share with Dr. Dipti. Dr. Dipti, can you have your camera on? Dr. Dipti, can you have your camera on? Dr. Dipti, are you connected? Or we lost your connection?
Yes, I'm connected. Fine, everything will be fine now.
Okay. So, Dr. Dipti, Bhanu Rekha has gone. So, who was the one? Pooja, you were the one who was okay. So, Dr. Dipti, assume that you are a resident who have just come in, and Pooja is the resident who is signing off. She's handing over a patient to you. She's sharing a set of information with you. Please take over from her. Dr. Pooja, please go ahead.
Right. Thank you, ma'am. So, hi, Dr. Deepti. There is this 14-year-old boy. The patient is a 14-year-old boy. He's on acute asthma. He's been diagnosed with the upper respiratory tract infection, and he's been on. Currently he's doing well, and he's been put on oxygen therapy. And we need to wean. Although he's fit to go, but we need to wean him throughout the night so that tomorrow he can comfortably go home. So that is it.
Dr. Dipti, is that okay?
I'm taking over. Sorry, I have no water. I'm supposed to ask a question which are still unasked.
It's your wish. It's all up to you.
Well, I would like to know, do we have his file in our hand, and what treatment has he received? So what is he receiving so far?
Okay. So that has been verbal to me, ma'am. So that's what.
Because I have been, the way we have been is always with the file. We always take over with the file.
Good. Because for me, it is all on the all in the oral format.
I know, Dr. Dipti, I deliberately gave the information in a slide form to the first participant. And this is how normally, see what you're saying, having a file in hand, actually signing and reading and asking question, I think that would have been the ideal handover. But we know we are far from ideal. So whatever information you have received from Pooja, if you can share that information with Dr. Ela, let's see how much I'll be able to really transfer her. And you did ask a very intelligent question, which I'm going to ask.
Well, Doctor, so I have to speak to Dr. Pooja.
Yeah, you are now handing over to Dr. Ela.
So I'm sure I have about 80% information. This is a Dr. Pooja. This is a 14-year-old boy who's a case of asthma, and he has been admitted with us. And he's been on oxygen, but now we are trying to wean him off. And not much issue otherwise, pneumonitis or anything. So I think that's all I recall.
So Dr. Ela, what did you get out of this whole handover?
First of all, Dr. Dipti did not talk to me. She was talking to Dr. Pooja.
Okay.
I understood.
I didn't have to listen. It was her Pooja and not for me. So true. So true.
I guess I was kind of distracted.
I got that.
Because Dr. Dipti was not happy with the way she was handing over.
That's fine. But still, I could hear whatever I could. I'll just say. I think I heard 14-year-old boy was admitted for asthma and was in oxygen therapy, and then now in the process of weaning off. And that's what I understood. That's what.
I think Dr. Gaurang has something to say. Let us listen to him first. Yes, Dr. Gaurang, please.
Yeah. Only thing that I realized throughout all this chain of transfer of information is that the content text, but when it's delivered from one person to another person, it's x plus 2, sometimes it's x minus 2, sometimes it's x by 2, or sometimes it's x square. I think throughout the conversation, one of the most important parts we missed is that the child was diagnosed with an upper respiratory infection. I think by the time it started from Namrata ma'am and it came to Ela ma'am finally, or Pooja ma'am, the entire concept of acute severe asthma was there, but the concept of URA was not there. Second thing is the baby is okay. When you presented it was written, maybe he might be discharged. From maybe he might be discharged tomorrow to he's fit for discharge. We have come a long way in these 7 transitions.
Absolutely.
And I think, yeah, as a doctor, 3 most important things which were missing was 1, patient file, patient data. Second, I think his present vitals are most important when we talk about handing over of any case. So vitals were missing. And when we talk about weaning of oxygen, it's important to know what is his present oxygen, how much is he receiving, and how much at what dose is the previous doctor who's planning to hand over, plan him to, actually gradually wean off. These 3 things were missing.
Absolutely. And so many other things, like you very correctly, you talked about, where we did not talk about the medicines that the patient is getting, nutritional status or hypoxia status. What is the oxygen that we are giving? What about infection? Is it controlled? Is it doing well? Is it improving? And then contingency plan. And if you saw, the whole focus was on discharge tomorrow. The patient is going tomorrow. The patient is going tomorrow. So what happens when we hear something like this? The moment you hear, okay, this patient is going tomorrow, what is the, feeling inside?
Your mind clamps shut. That
इसको कुछ करना नहीं है. He's getting
kind of feeling.
Exactly. इसको कुछ करना नहीं है. This patient is going, so इसका कुछ करना नहीं है. This is what exactly happens when we are given information like this. So when I ask nurses, Ramya, this is the example that you have given. I mean, you have given a very apt answer, a very apt example. When I ask nurses, where do you hand over and take over? They would normally say, "मैम bedside करते हैं हम लोग तो." नहीं, अगर अगला स्टाफ लेट आता है तो कैसे करते हो? मैम अगर अगला स्टाफ लेट आता है तो फिर हम नर्सिंग स्टेशन पे कर लेते हैं. अच्छा, अगर उससे भी लेट आता है तो कैसे करते हो? मैम फिर चेंजिंग रूम में कर लेते हैं, वो भी चेंज करती जाती है, हम भी चेंज करते जाते हैं, बताते जाते हैं, उसको वो सुनती जाती है. अगर उससे भी लेट आए तो क्या करते हो? मैम फिर हम गेट पर बोल देते हैं, जाते जाते सब कुछ लिख दिया है, देख लेना, कुछ प्रॉब्लम हो तो मैसेज कर देना, मैं बता दूँ.
तो WhatsApp.
और जब मैं डॉक्टर से पूछती हूँ कि हाउ डू यू हैंड ओवर एंड टेक ओवर, नहीं हमारे में तो हैंड ओवर टेक ओवर कुछ होता ही नहीं है, जो मैंने देखा वो तू देख लेना हो जाएगा। मैंने कहा नहीं फिर भी कैसे करते हो, कुछ तो बोलते होगे। तो कहते हैं हम ये कहते हैं ये सब ठीक है, ये 2 को देख लेना। इमेजिन ये हमारा टेक ओवर हैंड ओवर है।
Right.
और जहां बहुत राइटिंग पे एम्फेसिस है, डॉक्यूमेंटेशन पे एम्फेसिस है, ऐसा नहीं है, नहीं है। वेरी बिग हॉस्पिटल हैव अ वेरी वेल स्ट्रक्चर्ड हैंड ओवर टेक ओवर टूल्स. How many of us are really following it? You know, handover takeover, as I said earlier also, has become Bermuda Triangle of healthcare. Most of the information gets lost. In this case, if you look at the line that I have underlined, probably this is the only line that you will remember when you are taking over or handing over. So it's something like, you know, this is a cartoon by one very famous cartoonist. He says when a sender says something, he thinks I'm really delivering a very big information, very useful information. But the receiver receives only something that he or she finds relevant and meaningful. So it's something like you are talking to a dog, your pet. You say, don't do this, Ginger, come here, sit here, go do that. Ginger is just listening to Ginger's thing. Oh, I'm being called. So in a typical handover, when a resident is going off duty after 24 hours and is tired, exhausted, sleepy, and the next resident has come in, usually they'll say, मैं देख लूंगा यार, तू जा, मैं कर लूंगा, I'll manage. Similarly with nurses, the nurse who is in hurry to go, she has kids to look after, she has children to take from school, she has to go home and cook, and maybe the next nurse who came, अगर वो senior है तो वो कहेगी तू जा, मैं देख लूंगी, मुझे सब पता है यहाँ के patients के बारे में. And that's how we normally take over our handover. And you know, the cognitive processes that interfere with handoff, very common, are selective attention. So पूरा message जो distort हुआ, किशोर का नाम तो शुरू में ही उड़ गया, boy 14 years old, ठीक है. उसके बाद में किसी को URI याद रहा, किसी को सिर्फ आस्थमा याद रहा, किसी को ऑक्सीजन याद रहा, किसी को ये याद रहा, किसी को वीन ऑफ करना है. बाकी सब चीजें हमने ना पूछी ना बताई, because we all have this problem of selective attention, selective listening, and selective forgetting. So I'm going to show you a video. Maybe some of you have seen it, but it could be a repetition for some of you. Now, if you look at this video, I'll show you the instructions also. Give me a second to. It's just 1 minute video, but a beautiful video.
This is Lumen, the first device for hacking your metabolism.
This is a test of selective attention. Count how many times the players wearing white pass the basketball.
So I hope you know the task that you have to do. You have to count the number of times, how many times the basketball is passed by people who are wearing white dress.
How many passes did you count? Correct answer is 15 passes. But did you see the gorilla?
So how many of you saw gorilla? Did all of you see? All of you could see? What about others? Everybody could see? Now see once again. I'm sure many of you may not have seen it, isn't it?
This video is from research by Daniel Simons and Christopher Chabris and is copyrighted. It is available for use in talks, training, and teaching on DVDs from VisCog Productions.
I didn't see it.
Many of you, I'm sure, may not have seen. Initially, even I did not see when it came to actually Once I saw the video, then I realized, oh my goodness, we missed it. This is what exactly happens. These things become our blind spots. We don't get to notice that. Only Ramya rose her hand, that she saw it. That means either she had seen it earlier, maybe she was really observing it very keenly. But a lot of time we miss. So when we are taking over and handing over, we pay selective attention, and a lot of times selective listening and selective forgetting also, interfere with actual handover. As I said earlier also, most of the information gets lost because of ineffective handing over and taking over. Patient care handoff communication has become a critical safety and quality problem. And not just in India, according to JCI, all across the world. In a study where they tried to study the sentinel events from 1995 to 2004, they found that 65% of the reported errors, they were result of poor communication, which became 70% in 2005. And 50% of the times these were during the handoff. So you can well imagine the number of errors we are making when we are handing over. What do you think? Why effective handover is still a challenge? Why is it not becoming a norm or something that we are able to manage? What do you think is the reason why we are still struggling with it? What are the reasons? If you can. Why successfully we have not been able to implement it in real sense? So Dr. Dipti, this is going to really help you in understanding how do we really go about managing these problems. Okay, Dr. Virender has written, the fundamental challenge is lack of ownership. Absolutely. Others can write in the chat box and share their thoughts. Thank you.
Either we don't realize the importance of handing over and taking over, ma'am.
Absolutely. We don't realize the importance of it. Okay. Time consuming. We think it's time consuming. Absolutely. Lack of interest, monotony of work, responsibility. Absolutely. I completely agree. What else do you think? Time being an issue. Absolutely, Dr. Gaurang, you have really picked the one of the real reasons. I'll talk about them. Lack of interest. Yes. What more? What do others say? Lack of discipline. Yes, we are not able to discipline people to follow this system. We like to work at our whims and fancies, and then we find it too restricting for us to follow this system, especially when it comes to asking higher up people, consultants to follow the norm. They say, I don't care, this is the way I work. Then lack of basic communication skills. Absolutely. Lack of basic communication skills, use of non-verbal and interpretation. Absolutely. Hierarchy plays a role also in lack of communication. Absolutely. Overconfidence. Absolutely. Not being organized. I think you are really pointing to the real problems that we are all facing, and that's very true. And that is what is actually interfering with effective implementation of handoff. And if you look at some of the things, one is it's a one-way communication. Usually we think handover is somebody who has to hand me over. So I don't have to do anything, I have to just take. So we take it as a one-way communication. So it becomes monotonous. It becomes very monologue kind of a thing. And therefore it is becoming ineffective, because unless you clear, like for example, you did this activity. If in the beginning, if somebody had asked, what about medicines? What about IV? What about food? What about, in case if he develops, his condition deteriorates, so what do I do? So these questions should have been asked by the person who was taking over, but it was just taken as, okay, this is the information given to me and I just need to take this. Second is time. I think this is one of the biggest problems. If you have not kept time for handover, who will be willing to spend time for handover? In the case that Ramya shared, I think that's one of the rare cases. I don't think usually hospitals have functioning like this, but what we have seen, we have 8 to 2, then 2 to 8, and then 8 to 8. I think this is the norm we feel. Now the person who is going at 8 o'clock, if we expect that person to hand over, so if you even have, say, around average 30 patients, although in government setup we have 40, 50 patients, even if you have 30 patients, and if you think of handing over patient bed to bed, how much time do you think it will take to hand over each patient? Average?
5 to 10 minutes.
Even if we keep it very specific, 2 minutes, 2 to 3 minutes. If I spend 2 minutes per patient, and if I have 30 patients, that means at least 60 minutes. Who will spend 60 minutes extra unless that has been already integrated in the timings? So for example, if I have already said the next staff will not come at 8 o'clock, but they'll have to come at 7 o'clock. And the staff who is going will not go at 7, but they'll go at their time of 8 o'clock. That means we have kept 1 hour for handing over and taking over. So one of the major, I think, the failure of not having effective handing over is that we have not kept overlapping time. If we have already planned overlapping time for handover and takeover, there will be no confusion. There will be no, nobody would feel that, oh, I have to, go beyond my duty. But expecting somebody to stay beyond their working hours is absolutely inhuman, and that's not going to happen. And that's one of the reasons why we are having, then commitment, like many of you said, lack of commitment, lack of responsibility, lack of ownership. I think we have to bring in that culture of commitment, and that process has to be integrated with the system. Only then it would become a part and parcel of, daily patient care. But the problem is, as of now, there is lack of commitment from management side, from patient side. And then there are not processes available. For example, the example Dr. Dipti shared with us. If we had a process where the staff who will be handing over the patient from the emergency, gynae emergency to the ward or to the labor room, if we had a system where whatever they did has to be documented in such a manner that it cannot be missed, then the chances of missing that information are less likely. So we require some processes to make sure that these things are communicated effectively. Then there is extreme variability and uniqueness of handoff and transition in different care. For example, if it's a simple medical OPD of, say, district hospital or maybe even community, health center, and it's a neuro OPD, or it's a medical ward or a cardiology ward. So you can well imagine the variation and the uniqueness of the handoff. There'll be a lot of complex information that will have to be, handed over to the next team, depending upon the branch of medicine. And then, of course, we don't have any focused research to support our thought processes or to prove that how ineffective handover is leading to so many other complications. So research, a very interesting study that I'm going to share with you, that says what they did, they took 12 simulated patients. So what they did, they practiced 5 consecutive handover cycles in 3 different styles. So one style was that only verbal handover will take place. So these 12 patients, they were handed over 5 times in a verbal manner. So no written work. Second one was that, okay, we will be handing over in a standardized format. We will give you a format. That format will be handed over to the next person, and then to the next person, and then to the last person. And the third one was that we had a standardized format plus verbally we handed over. So what they found, the verbal handover resulted in loss of all data. When the note taking was, integrated, it resulted in loss of 31%. But when they used a standardized format with verbal handover, it resulted in minimum loss. So as I said, if you can integrate standardized formats, simple standardized formats to be handed over to the next person with verbal handover, it will ensure patient safety. Now, studies have also shown, and I think the cases that all of you have shared with us, that clearly shows that when we don't effectively hand over, it can lead to wrong treatment. It can lead to delay in treatment, severe adverse events, patient complication, increased healthcare cost, and then increased length of stay. I think all this you have already shared through your experiences. We don't require any evidence to it, but right here you have shared your cases, and we have seen this happening. Handoff is a two-way street to be shared. So it's like creating a mental picture for the other person. The sender is supposed to paint a picture what he or she has seen, give all relevant, important, essential information in the handover. Then specific directions, what needs to be done later. For example, this patient has to keep empty stomach, or this patient is posted for endoscopy, or this patient has to be sent to physiotherapy or whatever, and for what reason. And then also the sender is responsible to check whether the receiver has understood or not. Now, this handover practice that we did just now, if the person had asked, have you understood? Do you have any questions? I think a lot of discussion would have happened here, and a lot of information could have been assimilated by both of them. On the other side, the receiver is responsible to listen attentively, ask questions, use systems to remember important information. For example, the person who was receiving, if he or she would have noted down the salient point, and in case if there was something that was not clear, could have asked. And then at the end, he or she could have read back, okay, this is what I understand. Am I correct? So you are kind of repeating what you have received to confirm whether I have really understood or not. The whole thing is, handoff is not passing the buck, but it is passing the torch. A lot of us consider handoff as passing the buck. So we kind of, it's quick down and dirty exchange of few facts. Okay, this is what it is, take it over from me. I think one statement that will make the importance of handover very, very clear is, handover is never given. Handover is taken. The person who is taking over is responsible for the next 6 to 8 hours of the patient's care. And in case if something goes wrong, you are responsible for what goes wrong in your duty. So handoff is not a quick down and dirty exchange of few facts, but it is a coordinated effort among two professionals where both the giver and the receiver have important responsibility to ensure effective handoff. And each party must be comfortable with the information exchange. So clarifying, asking, repeating, they have to be part of handoff. So the definition of handoff is, it's a transfer of and acceptance of patient care responsibility. See, acceptance, that means, yes, I'm taking over from you. It's a real-time process. You can't say, we can do it later, or it was done earlier. It's a real-time process of passing patient-specific information, what happened immediately, what is planned next. So from one caregiver to another, or from one team of caregiver to another, for the purpose of ensuring continuity of care and safety of the patient. I think if these two goals we remember, there should be no compromise in the continuity of care and safety of the patient. We can never fail to take over properly. But I think we fail on this front a lot. So we have to really learn, handing over and taking over from, industries like nuclear industry, aviation, even dispatch. I was thinking, we get every day one or the other pack from Amazon or from, Myntra and so many other, online sellers. Not even once I have experienced any error in their dispatch. So how meticulously they must be working. As I said earlier also, healthcare is considered more dangerous than nuclear industry and aviation industry. It is safer to work in nuclear industry than getting admitted into a hospital. Not because they are more intelligent than us, because they are more organized, more systematic than us. We really need to learn from them the way they take over and hand over the processes, the way they have developed systems that cannot leave any place for human errors. So what are the kind of handoffs that you have observed in your system? Can you write in the chat box? Can you write in the chat box? Yes, verbal. Okay. No, that's okay. And what I meant was, in which areas, which all areas do we see the handoff? Like, for example, among nurses, we have seen nurses shift change. Where else have you seen handoff? Okay, billing. Labor room, fine. During duty change, absolutely. During duty change of the doctors, duty change of the nurses. Okay. Where else? Surgery. No, I'm not asking about the department. Like, for example, you're shifting one patient from your department to altogether a different department. The patient from medicine going to orthopedics. Or from orthopedics, the patient is coming to your department. Yeah. From OT to ICU. Or from ICU to OT. Yes, these are two different departments. Nurses, doctors, billing, duty change. Yes. Posted for surgical procedures. Yes. So that means patient is going either from ward or from ICU to the surgery OT. Absolutely. To new hospital. Yes. In and out of the hospital. So these are very common. Yes. Ambulance shifting for the higher facility. Absolutely right. Yes. Emergency, OT, emergency room, OT. Absolutely fine. So we have initiated the ISBAR. Yeah, we are going to talk about it, Dr. Pirendra, in a while. Yeah. So patient is going for ultrasound. Absolutely. That's also a handover. Transfer for diagnostic. Absolutely. So these are very common handoff that you must have seen. Nurses shift change. Level of care. Patient is in ward, is needing ICU. So we are moving the patient to ICU. Or patient is in ICU and is recovering, and you are moving the patient to the ward. So the level of care is changing. OT to ICU, ICU to ward. Doctors shift change. So whenever like doctor would sign off, he or she will hand over the patient to the next doctor on duty. Physicians transferring care cross coverage from a surgery to medicine or from medicine to orthopedics. So they are moving from one care area to another. Patients being transferred in and out of the hospital. So these are all very common handoff we all see. These are also part of handoff, for example, on-call responsibility. So when you are calling a doctor to come and see, for example, the patient is in ER and you are sending a call for neurology or gastroenterology or eye or ENT. So these are also kind of handoff where you are sending them a call to come and see. Even when you are sending a critical report, for example, in lab or imaging, the moment these departments come across a report that's worrisome, that's a critical report, the concerned doctor, concerned consultant has to be informed about it. So that's also a type of handoff. And then, of course, the hospital transfers, for example, the patient is being moved to another hospital, to another area, another district, or to a nursing home, or from nursing home to a hospital. So these are also part of the types of handoff. And like other transition in care area, like emergency department, radiology, physical therapy. We have talked about this. So this is one, a handoff tool a lot of hospitals are using. It's called 5 Ps, rule of 5 Ps. So in the rule of 5 Ps, it's a very simple, basic handoff tool where you talk about the patient, name, age, everything. Then what is the plan? What is the purpose? The problems and precaution. For example, patient Ram, 54 years, to be kept empty stomach for barium meal test. He is diabetic. The precaution you have to take is to check his blood sugar every hour so that we can check him for hypoglycemia. So these are very basic, simple handover. Problem is for complex cases or for cases with multiple other concerns, this kind of handover will not work. But yes, some of the hospitals are using this as a basic way of communicating patients' information. So if I ask you to make an attempt of that case that we saw in the beginning with 5 Ps, so can you try writing in the chat box? Don't click before unless you have completed what you want to say. Do you want me to repeat those 5 Ps? Give me 1 second. Yeah, I'll put that in the chat box. Yeah. So I'm writing in the chat box. 5 Ps. Yeah. And this is the case I'm showing once again. Okay. So try converting this information in the form of a 5 P. I'm sorry, I forgot to keep water for me. Give me a minute to get my water. Meanwhile, you can do this activity. Yeah, I'm back here. Yeah. Kishore, 14 years old, plan is to be enough oxygen tomorrow because we are discharging him. Okay. Check oxygen requirement for discharge, URI. Okay, very brief, huh, Dr. Deep. Now you see what happens. As I said earlier also, concerns like medication, nutrition, hypoxia, infection, contingency plan, all this cannot be covered in these 5 Ps. And therefore, even those 5 P rule will not work here, will not be very helpful. We require more information. We require more information. So we'll talk about that. And we'll be talking about a couple of tools. By the way, what are the barriers when it comes to actually sharing this information? Can you think of some barriers? What are the barriers that you see in your system that comes, in the way of effective handing over? Knowledge of what we are doing and why. Yes, some people lack that knowledge. Dr. Birendra, although you have said especially between nurses, I agree, but a lot of time even I've seen doctors being ignorant of it. Especially doctors who are not trained in a setup where they actually worked with the patient. A lot of time we are getting doctors from, who are trained in hospitals where they haven't seen patients. And there we have a real challenge, about their knowledge and skill. Absolutely. Attitude of people. I agree. Yes, that's again assumptions. That yes. Namrata, what do you mean exactly by assumptions? Can you explain in your words?
Ma'am, by assumptions, I mean like while giving handover, there are certain cases which I will say ki some details I'll not mention. I'll assume that अरे ये तो basic चीज़ है. He or she would be knowing it. So
Absolutely.
something like that, like in every department.
Absolutely, I agree. Yeah. So Ramya says language, absolutely. Language, noise, they definitely interfere. Technical language, yes. A lot of time we use some words the other person may not understand, but may not even ask. So especially, I was, taking a session for a group of residents. So one of them said, ma'am, my consultant speaks so fast that I am not able to actually understand a lot that he says. And I'm too scared to ask him to repeat. So what I do, I'll just keep saying yes, yes, and then after he's gone, I'll ask my fellow residents ki kya bol ke gaye, फटाफट बताओ मैं note करूं, मेरे से miss हो जाएगा. But tell me, is that the right way? There's still a scope for missing some vital information. So those kind of errors are very, very common. Miscommunication, yes, stress due to being overworked. Exactly, that's what Monica you want to say. Stress due to.
Yes,
patient nurse ratio. Okay.
Yeah.
Patient nurse ratio, doctor nurse ratio, doctor patient ratio. Absolutely. I mean, especially in government setup, we know the kind of stress they are experiencing. Always in hurry, time constraint, overlapping. Yes, that means there are a lot of reasons for ineffective communication that you will see. Some of them that I have noted on are something like many of you have already mentioned. Just 1 second, where are we? Activity. I think I'm missing on something. Okay, I think before we talk about that, just a point here. This activity I would recommend you to do wherever you are, wherever you want to apply or initiate ideal handoff to your testing. So what I would suggest here, that instead of giving them a ready-made handover tool, this activity I normally do when I have full day or half a day to talk about only handoff. So what I would do, I will make participants, individually identify 10 things that they think should be part of an ideal handoff. Ask them to do individually. Then make them sit in a group of say 4 or 5 people. So example, if there are 30 participants, so you can have 6, groups with 5 participants in each group. Ask them to discuss between them and then come up with final 10 items that they think that are very essential for an ideal handoff. And then those 6 groups will discuss and come up with the final handoff list. So there are 2 things. One is that their acquaintance with handoff will improve. Their understanding of handoff will improve. Second, they are going to come up with their list of handoff or items on the handoff. Chances are their commitment to handoff also will increase. So I did this with a couple of hospitals and I gave them this as a final, outcome of the activity, which they tried implementing. Of course, from there you can diversify. You can develop your own requirement depending upon your requirement. But then to make a beginning, this is one activity you can do with your team, with your audience, wherever you want to bring a change. So this is what I would do, and this is what came out after the activity. They will say we need to know the identification, the diagnosis and comorbidities, present treatment and response of the patient, chief complaints and intervention done, then vitals including sensorium and general health, any adverse event that happened before we came or expected, plan of care or any pending plan, any investigations done or pending, medication, intake output. So according to them, according to a lot of groups, this is what came out as a final ideal handoff they want to have when they receive the patient. So that will become part of their, this is the activity you can do with your. So I was discussing about the barriers to effective communication. Sorry, I missed this, so I thought I must bring it here. So the barriers, as you said, a lot of you identified the right thing. One is complex system. As I said, healthcare delivery has become very, very complex. If you go into, a neuro ICU or into cardio ICU, you get overwhelmed seeing the machinery, seeing the equipment, seeing the medicine, seeing the tubing. So, and then handing over everything in a systematic manner can become very, very overwhelming for anybody, for doctors and for nurses. Then the volume of information is also very high, very difficult for anybody to comprehend. Then time constraint, as we discussed, that we haven't kept any special time for it. So everybody is hard pressed. Somebody is in hurry to go, somebody is in hurry to take over. So we miss information for this. Then there is a limitation of learning and training. Now, some of us who are trained in very elite hospitals or elite setup, we are familiar with these things, but many of us come from a very humble background, from a very humble, organization. So there maybe we are not exposed to such training, so it can be overwhelming for them. Then there can be continuity gaps. For example, you handed over well, but the person who took over did not hand over. The whole thing got, haywire. So there can be continuity gap. Human fallibility, like we talked about selective listening, selective forgetting, selective attention, memory can be an issue, attention can be an issue, concentration can be an issue. So all these are common errors. Negative impact of fatigue. When we are tired, when we are sleepy, when we are exhausted, we make more mistakes. We are likely to forget things. Confidentiality can be an issue. You got some information from the patient. Now you don't know whether you should be sharing or not. For example, a patient shares with you about, molestation or physical abuse or even intention to attempt suicide. One may wonder whether I should be sharing with the others or not, because you may fear that, okay, I will be breaching my patient's trust if I share this. So that can be a barrier. Then, of course, we all know there are differences in styles of communication. Some people are wonderful communicators. Some people have difficulty framing even single sentence. And we know that they fumble with the word, they really struggle with their language, they struggle with their expression. So best thing they will choose is to keep quiet or to speak minimal or not to speak at all. But that really interferes with, handing over. Language we have seen is a challenge. Those who have good command over language, they're able to speak well, but then we know we have people from different parts of the country. We have almost 20, how many languages we have? 22 or 24? Any idea? How many languages we have?
22 official languages.
Yeah, 22. And there are 720 dialects. So you can well imagine how language can be a barrier. Then there are gender differences also, in communication. Then cultural background can be a problem. Some people are comfortable talking to males, some people are not comfortable talking to males. So there can be a barrier in that way. Hierarchy of decision making. So if I'm not part of the decision making, so I will not probably even think it important to pass on the information. I may keep the information with me. I'm not the one who's going to decide. So they are going to decide. So let them handle it. Also, if the level of respect between the doctors and nurses is not like really good, there can be a challenge in communication. And we know it, this happens. And level of empowerment. If you empower your team, your nurses, your technicians, your support staff, they are able to communicate effectively whatever their concerns are. Very common, these challenges you will see when it comes to doctor-nurses communication. One is differences in the style of communication. Especially people who are aggressive, dominating, authoritative, they would, like Ramya said, he came, he said, who's the patient who's to be, put for echo? We couldn't respond and he went away. So then after that, we had to go and say him sorry 100 times to ask him to come back and do the echo. Now, you can well imagine in such a kind of arrangement, how would you really find comfortable interacting? Hierarchy, we all know, is a challenge. Past experience, if you have been rude to somebody, or if somebody has been rude to you, you will never feel like interacting with that person who has been rude to you. So chances are you will avoid talking to that person. So reporting will go down, passing of information will go down. Level of empowerment, how much do you really empower your staff to talk, speak? Very, very important. Tone of voice, if the tone of voice is harsh, rude, authoritative, intimidating, definitely the other person will not come up with complete information confidently. He would always be scared to be, treated badly. Again, level of respect, language. So these are all very common, barriers that come in doctor-nurse communication, where the nurses may not communicate effectively, especially with senior doctors. So they may not speak up very confidently and clearly. So these are some of the tools. Who all have already heard of some tools? Like Dr. Birinder talked about ISBAR. Have you heard of any other tool? Anybody?
Yes, I have heard.
Can you write in the chat box the tools that you know?
I should write what is ISBAR?
Yeah, no, not ISBAR. What other tools do you know?
Okay.
ISBAR is one. Any other tool you know? There is one ISBAR, then there is one SBAR. Then there's one I pass the baton. Then there is one sign out. Then there's one MIVT. There are many more. There are a lot of them. So ISBAR, I think, is most commonly used tool, in a lot of hospitals. So briefly, what is S bar? S is where you talk about the situation, about the patient, giving the detail, then identify reason for this communication or describe your concern. For example, if it's a patient admitted for cataract surgery, so you will be saying, okay, that this is a patient for cataract surgery. Then you talk about the background. So background will be, according to you, what is the background in terms of comorbidities, medication, investigation, treatment. So if you say, okay, this is the patient admitted for cataract surgery, patient is diabetic and hypertensive. So this is the background. Assessment is your assessment of the present situation. So what is your present understanding? So his diabetes is in control, hypertension is in control, he's on medication, both the, and cataract is mature. So that's your present assessment. And then recommendation. So what do you recommend? So recommendation means pre-op, maybe in this case, it will be more like pre-operative instructions that you want to see. Tomorrow morning, the patient has to go for surgery. So in the morning, the patient should take bath, wash his head, and remove all dentures and artificial jewelry and all jewelry, and then wear loose clothes, and then eat light breakfast and take both the medicines for diabetes and hypertension. So these are the recommendations. Very clearly you are saying. ISBAR has been modified into ISBAR. Now, what is ISBAR? I stands for, first of all, they give a lot of emphasis on introduction and identification of the person. So when we say introduction, see, this is ISBAR, introduction, situation, background, assessment, and recommendation. So I has been added to it. So in I, it is, you need to give your introduction, especially if you're calling somebody. For example, if I'm calling another doctor on phone, so I first need to tell who am I, from where am I calling, about whom am I calling. So state your name and unit. I'm Dr. So-and-so, I'm nurse so-and-so, from ward neurology, from ward medicine. So you identify yourself. Then you have to tell about the patient about whom you are calling. So I'm calling about this patient Ram on bed number 6. So you lot of emphasis is given on I, because usually when we call and say, doctor, I'm calling from ward 8, patient ko bahut dard ho raha hai. Now this is a very incomplete kind of a communication. Who am I? Am I doctor? Am I nurse? Am I intern? Who am I? Or ward 8, patient ko bahut dard ho raha hai. Who is this patient I'm talking about? So I is about introduction. S is when you tell about the present problem, or it could be about the procedure, it could be pre-operative observation, changes in vitals, changing in mental status, or patient's change in stability. So if you say this patient is having a drug reaction, or is pre-operative, or changes in the vital, so what is the present situation you are talking about? Then background is about little more information that will help the person understand the background of the patient. So if I'm calling another doctor, so I need to give more information for that doctor to visualize whom am I talking about. So maybe you will talk about the medical history, the allergies, sensory impairment, family location, religion, whatever is related, not everything, whatever is related to help the person make a picture about the patient. And then your present assessment. What is your assessment about this patient? It could be about vitals, it could be present condition, if there's change in sensorium, if the pain has increased, or the bleeding has increased, or there is some critical lab report that you have received just now and you want to communicate, or there's a change in the skin condition, or if there's any risk factor that you have been able to identify, maybe the patient appears suicidal, or patient has become aggressive, patient is hitting everybody, patient has locked himself or herself in bathroom. So all this could be risk factors maybe you would like to talk about. And then issues that I'm concerned about. So what is your immediate concern? That will be part of your assessment. Then is R. R is what is your recommendation, or what are you requesting for? So maybe you would like to say that the patient requires injection, painkiller, or the patient requires oxygen, or patient requires, some medicine for fever. So what is the priority area that you are, asking the person to intervene into? It could be pain control, it could be the IV pump, it could be even family communication. Their family members have come and they're really, arguing. So I request you to come and speak to them. So I would recommend to call their family and speak to them. So that's your recommendation or your request. I think ISBAR is being used very, very commonly. Similarly, I pass the baton. So in this, I stands for introduction. P is your patient's name, identification. So in this, I and P have been bifurcated. Then, of course, the assessment, what is the problem right now? Then S is situation, what is the current situation for these current circumstances? And then second S is for safety concern, in case there is any lab report, critical lab report that you want to be discussed or want to inform. And then any threat, pitfall, alert, all that is part of the safety concerns. BETN stands for what is the background, comorbidities, previous episodes, current medicines, family details, etc. A is actions. So what are the actions to be taken? So what do you recommend? What actions do you recommend? And brief rationale for that. Timing, how urgent? Is it immediately you want the doctor to come? Can they come later on? Can you like you kind of tell the urgency of the situation? And then ownership, who is responsible? So for example, the patient requires blood and the responsibility of arranging blood is on the patient's family. So is it patient's family or the patient or the nurse or doctor on duty? That's clearly spelled out. And then next, what happens next? That is anticipated change and contingencies. Anybody in their hospital, are you using I pass the baton? Anybody? Anywhere if you have seen?
They're using S-bar.
ISBAR. I think ISBAR is most common. ISBAR is the most common one we are using. So Dr. Dipti, have you heard of these handover tools?
No.
No. Whereas these tools actually make the task of, communicating very simple and direct, because you know that it's not the person is going to say anything and everything. So once you follow these, tools, they make the information very specific and to the point, and then you don't miss the important points in that. So there are any other hospital who are using ISBAR or SBAR, Karan, in your setup? No. I think Dr. Ila's hospital is using ISBAR. Am I right? Okay, Ramya says we are using. Which one are you using, Ramya?
We have made some changes internally, but basic is ISBAR.
That's okay. I think it has to be customized. Absolutely.
Customized, yeah.
So Ramya, which one are you using in your setup?
And we are using ISBAR only. We are training them to use ISBAR while they are having a verbal order, because we are a home setup healthcare company. So basically, whenever we are able to generate any observations or assessment of the patient, so we have a on-call doctor and a nurse manager. So that time we teach them what and all things you have to tell to the doctor or the nurse manager about the patient. So this ISBAR we have been teaching them and they are following.
Absolutely. I think that's very important. And that really, does that help, Ramya? You find it useful?
Yes.
It's useful.
Yes.
Absolutely. Even I feel that if we have a proper, structure to communicate, then you're less likely to miss on important information. So this is another, report writing tool. For example, SOAP. This you may have, in case you have seen my book, I have talked about it when it comes to documentation about SOAP as a, documenting protocol. So in this, you give subjective data, then you give objective data, then you give assessment, and then plan for patient management. So you will know that in this structure, I'm supposed to be writing patient's details. Similarly, in case of a report of injury, if you are using MIVT, that is mechanism of injury, injury is noted, vitals, and then the treatment. So MIVT is another reporting tool that is being recommended. So the whole idea about using this communication protocols is that you not only are able to communicate effectively, but also to ensure that actually the required action is taken. For example, when you're communicating, talk to the person, get their attention, and then talk. Make eye contact if it's possible. If you have face-to-face communication, it's always good to look at the person and talk, and then use the person's name to whom you are talking, so that the person's attention is received. Express concern, whatever your concern is about. Use ISBAR as a technique. In case if you think that required action is not being taken, maybe you have called the doctor and the person has not come, it's important to reassert. So you have to probably inform again or call again or repeat your call. In case if the decision is not reached or the person is not responding, then I think it's important to escalate if necessary, because the idea is that action has to be taken on in case if you're calling somebody for help. So this is one exercise I would suggest you to do now, if it is possible. This information, if you can convert into ISBAR and write in the chat box. So let's take this example. Take 2 minutes time and quickly and write in the chat box. So you can identify yourself also as a doctor or a nurse on duty, and then also identify the patient. So I hope you're working on it. Okay. I'm Dr. Shashi, calling out for Mr. Rajesh, 50 years old. S is he has multiple injuries. Okay. So when you say I am Dr. Shashi, intern, resident, then from where am I calling? Is it ward? Is it OT? Is it ICU? Is it emergency? So I'm calling from emergency department. Okay. Myself, Dr. Ramya, doctor from emergency department, just received a casualty, Mr. Rajesh, 50 years old with RTA. No background of the patient is known. The patient has stable vitals, multiple injuries all over the body, no grievous injury, but complains of diplopia and confused. I suggest, can we have a CT of brain? Okay, that's your thing. Good. Ramya, good attempt. What about others? So this is one example that's good. Okay, I'm Mr. Rajesh, 50 years old, doctor, nurse introduction is missing, multiple injuries all over body, diplopia, vision, history of RTA, brought by police, vital stable, grievous injuries, no grievous injuries, slightly confused. Cannot see any recommendation. Okay. I'm Dr. Ila from ICU. He is a patient, Rajesh, 50 years old. Multiple minor injuries, no grievous injury, brought by police, diplopia after accident, vital stable but confused, needs monitoring. So you can see how our recommendation is changing or assessment is changing differently. So this is one example. But if you're able to train your people to use this on regular basis, slowly they'll come up with very clear ISPAR. I'm Dr. So-and-so on duty. I would like you to come and see this patient, Rajesh, 50-year-old, on bed number 3, complaining of diplopia in the right eye. Background is that it is a RTA case brought an hour ago by police, multiple minor injuries all over the body with no apparent grievous injury. Assessment is his vitals are stable, but seems to be slightly confused. And recommendation is, will you be able to come and see him at the earliest? What would you like me to do in the meantime? So this is something that you really need to train your people to work on. Similarly, this is another exercise. We are short of time, otherwise I would have given another trial on this. But we can try it. So finally, if you look at the benefits of standardized communication that we are talking about, the focus is not on the healthcare provider, the focus is on the patient, because it's not who is communicating, it is about whom we are communicating. So we have a proper format. So if we use the standardized format, it allows all parties to have common expectation. What is going to be communicated, how the communication is structured, and what are the required elements. So automatically, you will not miss on any essential information. If you are thinking of starting to implement something like this in your setup, these are a couple of suggestions that will really help you. One is assess all points where handoff occurs. Right now, how that process is happening, monitor that. You'll get to know the gaps that you need to fill in. Then instead of applying it all across the hospital, identify your champions. They could be your physician, nurses, and other leadership who will take your task forward. Then select a consistent approach to handoff. Maybe you ask them to identify what needs to be handed over, or maybe if you have a tool that you want to be tried and then modified, that's your other choice. But select a consistent approach to handoff. Develop a policy and procedure around it. Educate your staff whom you want to participate in what you're doing. Implement that policy or that tool, and then monitor and report your findings. Keep updating the procedure. So ultimately, you will find some changes and tweaking required, which is perfectly all right, which is doable. And then you can come up with tool that is useful and serves the purpose of your setup. So the benefits of proper handover are there's continuity of care, there's patient safety, decreased error in patient care, decreased repetition, and then definitely there will be more patient satisfaction. Take home point. So what is your take home point? Rather than me saying, I would want you to tell me what is your take home point from this discussion. If you can write in the chat box. Involvement of staff as a team is necessary. Absolutely, I agree with you, Monica. If you are able to involve them, your implementation will become easy. Proper method use, uniformity of communication makes less or no errors. Absolutely, I agree. Look for situations to implement ISPAR. Yes. Look for simple areas initially because you want to give them the taste of success. Then it will be easy for you to implement to other areas also. Handover cannot be taken lightly, must be given with utmost importance by management. Absolutely. Management has to be committed to it. So sensitizing the staff, the importance of handover. Yes, I think that is very important. Handover importance and standardizing as per departmental requirement. Yes, you will have to really customize. Nothing, no one tool can be used for every area. You will have to really customize it. Any other takeaway? Yes, participation approach works for better implementation. I think that's for every quality implementation. Every change that you want to bring in, if you're able to engage them, you have them on your side. Structured handover can change the face of a hospital on a panoramic viewpoint. This can also improve the medical staff interaction and learning, definitely. And there'll be huge satisfaction coming out of it. Patients are satisfied, we are satisfied that we're doing in the right manner. Staff involvement and induction is required, so things become easy. Absolutely, Dr. Ramya, I agree with you. CAPA should be definitely done. Oh yes, I think I always talk of CAPA. That's the only approach to bring change. If you don't use CAPA, you will talk about the problems, you will never have a solution. So very mindfully pick up small areas where you think you can change, you can bring change. And you can see, if you have read that book, Atomic Habit, even 1% change every day brings 37% change at the end of any year. 1% change. Yes, absolutely. I have a soft copy with me. I even have a hard copy here with me. So Atomic Habit is something people who want to grow, they have to keep updating themselves and find new tools to, try hand with. Otherwise, you can't find solution. 1% change. And it can bring 37% change at the end of the year. Huge change. 40% is not a small change. But one step at a time, we have to. So this brings us to the end of this session. I'll quickly share the feedback form with you. I want you to finish your feedback for the session, and then we move on to the presentation. Any questions meanwhile, when I'm pasting the... Any questions, any feedback about verbal question, doubt or discussion you want to do quickly? See, even if there was one, I don't think it would make any sense, because the execution has to be done by us. Unless it is brought to my awareness, I will never, work on it. Yeah, Dr. Ramya, you want to say something?
Madam, I missed your one of the slide where you were asking about the suggestions implementation, the first slide. So I was just trying to write it and I was not able to.
वीडियो आपके पास आएगी स्लाइड्स आप देख ही लोगे.
और दूसरा मेरा ये है कि we all are working in a medical field, but all of us must have learned only through mistakes and all those things. But we should always sensitize ourselves as soon as we are coming and entering this department, that we can't learn from experience, because it always is going to affect some human life. So absolutely. I think we should sensitize, and always in our students and wherever we are able to train, we need to give them good incidents, happenings which have happened, so that we make them sensitized from the first year, second year, so that we are trying to reduce errors. I always tell my students, see, if you're going to do something, the patient is going to suffer. He might die also. So always think when you're doing it twice. So I don't know how many I have affected and how many students have learned from me, or whether they're executing or not, but I would just like to...
No, definitely. You should talk about the possible errors. Let them not go with the idea that we are error-free. Rather, they should be scared that we make a lot of errors, and we have to be careful when we are handling patients' information. Absolutely. Absolutely, I agree with you.
Our medical director, he always used to say, when your parents get sick, how confident you are to make them admitted in your hospital.
Yeah, absolutely.
That is the confidence we have to give it to our patients.
Absolutely, I completely agree with you. So if you all have
ICU nurse, I don't have actually, I really have a fear in a department that is ICU only. I always fear any of my relatives go to ICU. I really have a fear, and still it's there with me.
And when I tell you that book, Atul Gawande, he says there are possibilities of at least 4 errors every day for every patient. So keep your fingers crossed. So I've received 4 responses as of now. I request all others to quickly complete so that we can move forward.
Ma'am, I'd request you to resend the link. Like today, I don't know something. There's a sandstorm here near my place, so the connection's like haphazard, on and off. So in order to save that, I kept my video off throughout the session too. It's been pretty bad here. Just now the power has come back. Otherwise, I was working on with my mobile data.
Oh. I've shared the link. So after you have done it, if you can write in the chat box, I will know how many of you have done it. It's showing me 5 responses. That's all.
Dr. Indu, it's regarding the feedback form, no?
Yeah.
Yeah.
Done, ma'am.
Thank you. So we are left with only 2 more sessions, but very important topics to be covered. One is breaking of bad news, and second is disclosure of error, disclosure of medical error. So we'll have some role plays around it, some discussion and protocols that can be used to learn how to go about doing this, both breaking of bad news and, oh, sorry, my video is off. I didn't realize. Sorry. So I know you are not missing any session, but I would request you to join on time and start on time. Yes, Dr. Gordon, go ahead. Yeah.
Ma'am, I just had a request which I wanted to place. If everyone's comfortable, like next Saturday, that's the 21st of May. If it's convenient with everybody, could we join a little late, like 8:30 or 8:45? Because 2 reasons. I know if it's comfortable with everybody. Otherwise, I would request you to exempt me from joining on time. Like I might join a little late because 2 things. One, I have that NEET exam that day. And the second thing is that my course with Harvard, it starts on May 21st. Like post exam, I have my first session with them, and according to the Boston time, my course will run up to 8:30 p.m. Indian Standard Time. Then I have another session from 12:30 a.m. to 5 a.m. in the morning, like my time, but their time it's the evening time. So if either 2 things, either if it's convenient with everybody and I can also pitch in, it would be. I'd be really grateful. But if it's not convenient with everybody, I would request you to exempt me from joining on time, maybe a little late. I'll pitch in by 8:30, 8:40.
I'm okay with whatever group decides. So Dr. Ramya says, can we have it on Friday? But I think Gaurang will be very occupied with preparation for his entrance. So I don't want to.
Yeah. Friday, I'll be on the blazing furnace.
I know, I can understand. What is the other way out? So your Harvard program is also on the same evening, Saturday?
Yes, ma'am. Saturday, one program is from 5:30 to 8:30, and the second one's from midnight, like 12:30 a.m. to 5 a.m.
So I'm not sure how many of you will be really comfortable. 8:30, Dr. Monica says 8:30 is okay. What about others? Is 8:30 okay to others? You can say yes or
because no, I have my presentation as well. Next week, Deepti ma'am and I, we have our presentations. So that day I have my presentation as well. So if everyone's comfortable, otherwise I can log in little late if it's convenient with you, ma'am.
So I think only 2 people have said they're okay with 8:30. What about others? 3 people. So what we can do, we will not extend beyond 10:30. Because after 10:30, it will become too much for anybody to sit. So let's start at 8:30.
Okay.
And finish by 10:30. And whatever is left, we can cover in the next session. Is that okay? Chalo. Thank you. Thank you everyone for being so understanding. That's
Yeah.
so nice.
Thank you so much. Like 2 more things which if I would like to share. First of all, thank you for understanding and doing this for me. Second things, 2 things. One, today is my birthday.
Oh, wow.
The second thing is I also got my National Institute exam results today. So I fared well. Like I got 94% and I think that's one of the best birthday gifts also. I got a decent rank of 3000K, but I mean 3003K, but I might not get OBG, which is my subject of choice. But nevertheless, for my preparation, it paid off. So 2 more.
Wow.
Thank you.
Congratulations. Congratulations. I wish we were together. We could have asked you for a party.
No, but I'm sure if we all like, ma'am, maybe once you come down, I think most of them are going to be based. So if you of us who are not in Delhi can fly down to Delhi or places nearby, we should get together for the program. I mean, just celebrate the success.
Definitely. Thank you. Wonderful. Very good news from your side.
Thank you.
So wish you best of luck for your exam over the next weekend, and then we meet at 8:30.
Thank you, ma'am. Thank you all.
Thank you.
Thank you.
So can we, sorry. Yeah, Ila, you were saying something. Go ahead, please.
No, I said the same thing. Thank you. All the best, Dr. Gaurang.
Thank you.
So if we may quickly start with the presentation by Bhanureka and then Dr. Shashikala.
Oh.
You're ready?
Yeah.
So you'll have to be always ready. So what I would say, if we stick to 15 minutes or maybe lesser than 15 minutes timeline, then by 10:30 we can close it. It is 10, I think. Am I right? Or 10:05?
10:05.
So try to keep it to 10 minutes. I think Madhurika has done a lot of, redoing and preparation. Even Dr. Shashikala did a lot of redoing. So I think you will be able to, control the time. If you can control that factor, will be really good. So Madhurika, are you ready?
Yes, ma'am.
Wonderful. So I'm giving you the rights to share your screen.
Yeah.
I'm sorry, I touched on the wrong point. Yes, now you can share your screen if you want.
So can everybody able to view my screen?
Yes.
Yes, you can see.
Okay. So once again, a warm good evening to all my colleagues. My topic is going to be about creating interesting activities around the topic. So who doesn't like an activity? Everybody likes to be involved in activities. We like to involve in the fun game, and we just forget our age and we try to bring in our childhood again. So I hope everybody will agree to this point. Everybody would love to play. And when we start involving in our play activities, we just forget ourselves. We just try to be on the shoes of the kid. Like we become a 2-year or a 1-year-old kid and we just try to adapt them with the activities. So as in like we can involve these type of activities in the training too. So that is going to be my topic for discussion today. I'll just play a small video. Just tell me what could be my topic based on this video.
is called the tank. The objective is the sighted person in the back is supposed to guide the unsighted person in the front, pick up pearls off the ground and place them in the bucket using nonverbal communication. Hopefully they don't rip each other's heads off. Once they get the terrible toss score, they drop it in the bucket. As you can see, we have two teams going currently. And once you drop in the bucket, pick up the blindfold, you rotate back the group, you can decide to continue to go with the person who was first. Back. Good job, group. Original group, Amos group, good job. Randy, I would encourage you to stop. But they don't run into the wall. Good job, team.
So you can just post it in the chat box. What could be the topic related to this video?
Ramya says team player.
Team play.
Mita is saying follow the leader. Perception through senses, absolutely. Chain of events. Vanreka, please read if you are comfortable.
Yes, ma'am. A chain of events, lead the show, senses evaluation by Gaurang. And I hope the best guesser will be Pooja Swaroop, team building. Exactly, Pooja. Thank you so much. So that will be the topic. Most probably when you're just involving in a topic like team building or a non-verbal communication, for both the topics, you can just go with this video probably. So it is team building activity with non-verbal communication. So this is how you can just give an activity, or to start the topic, you can just initiate it, or it can be in between the activities, or at the end of your session also these activities can be involved. So let me discuss some of the advantages of this type of fun activity in the training interaction. It would be more motivating for the trainees. Attentiveness, you could fetch a lot of attentiveness from the trainees. Problem solving method could be more, and it could be self-esteem boosting for them. It could be more interactive. The session can be more interactive if we can include a lot of fun activities in the session. It can also improve the critical thinking of the learners, and it could even be an icebreaking happens quickly. It creates interest among the learners, and there could be more cooperation than you can expect in the session. And same, we have a few disadvantages of conducting this activity. Like, hope everybody, if it is a mixed group, everybody will not be comfortable in playing the game, since it's a mixed combination of male and female group. And sometimes if there is an hierarchical borders, maybe from superiors to inferiors, they might feel less often offended if somebody is giving us some sort of sign of non-verbal communication. This activity, but it could be create a lot of friendly atmosphere both. But unless and until if they avoid a physical or verbal touch, and make sure the time should not be exceeded, because as we know, when we involve a lot of fun activities, we cannot restrict to a time. So for example, if we plan for a 10-minute game activity, That some might could extend, if the learners are too much, it could extend for 20 to 30 minutes also. So always make sure it should not go over the board. And some do's and don'ts. Make sure that activity, whatever we are planning to conduct related to the topic, should be relevant, and it should have a contextual and a definite message. And make sure that our activity is time planned, it is well planned, and it should be short and it should not be much lengthy and occupying much of our time. Resources, whatever that is going to be available for you on that day for a session, could be used effectively. Activities should definitely convey the topic. Whatever activity they are trying to project for the training program should definitely convey the topic. And the cultural aspects also should be kept in mind. For example, for an Indian scenario, tapping on a third person shoulder or just kicking on his foot will not be accepted. So taking into the consideration all the cultural preferences will also be greatly appreciated. Safety aspects that has to be considered, and you have to plan as per the group's understanding. Sometimes when we give a proper planned activity, when the learners group is unable to understand, there is no point in conducting the session, and it will not be effective for the learners too. So where all this type of activity that we can use in our training session or when we conduct a program, when we want to introduce a particular topic, maybe giving some activities based on that, we can introduce it, or in between the session as an ice breaking activity, or at the end of the session, maybe to reinforce your topic that what you have taken for the day. Even this activity can be used, or to make the formal atmosphere much more relaxed. This sort of activity can be practiced, or even it can lift the energy of the group. If you feel the group is little low while taking the session, to lift their energy also, this sort of activities can be planned. So that's my session, and thanks for the wonderful opportunity given by Dr. Indu. Thank you, ma'am. Thank you all for your patience listening.
Wonderful. Very quick, very short, and to the point. Thank you.
Thank you, ma'am.
Thank you so much. I think more you are comfortable with using these activities and you are integrating it in the program, more impactful it will become, more engaging it will become. Because people remember experiences. But we have to always remember, a lot of time I see some videos, there is a lot of action, but there's no message. People go back with just a feeling, oh, it was fun. So you have to really strike a balance. It has to have an element of fun, but without a concrete message, I think it would lose its purpose. But otherwise, if you can integrate an activity to highlight a point or to initiate a point or to conclude a point, that's a wonderful way of doing it. Don't make it too complex, too difficult for the organizers also. Don't ask for such material that is not available and you have to buy to just do the activity. But be little creative and you'll really find these activities very helpful. So thank you, Bhanureka. I think it was a very good presentation. Yeah. So if you can stop sharing, we can ask Dr. Shashikala.
I've stopped it now.
Okay, Dr. Shashikala. Yeah, we are already seeing your screen. I didn't realize. Go ahead, please. Yeah.
Good evening, everyone. I know I'm starting straight away with rules, but I'll be narrating a small story. Even though at the beginning of this session, by Dr. Indu, she explained already a story. So I know how story can be so simple and experience itself can turn out to be a story. But let me start now. A farmer in ancient China had a neighbor who was a hunter and who owned ferocious and poorly trained dogs. They jumped over the fence frequently and chased the farmer's land. Farmer asked his neighbor to keep his dogs in check, but it fell to deaf ears and he never tried to bother about it. One day, the dogs again jumped the fence, attacked, severely injured all the lambs also. The farmer had enough. He went to the town. He had to consult somebody, so he thought he'll go to the judge. He carefully told all his sufferings to the judge, and judge was listening very, very patiently. Then judge told, I could punish the hunter and instruct him to keep his dogs chained or lock them up, but you would lose a friend and gain an enemy. Which would you rather have, friend or a foe, a neighbor? So if can anyone tell what the decision the farmer has to make here? Like, should he go ahead with asking for a judgment from the judge, or should he continue? Can you hear, all of you?
So Dr. Shashi, are you showing anything on the screen, because we are not able to see anything?
Yeah, ma'am, I am not showing anything, but I don't know why it is not sharing.
No, we are able to see your screen. That means you are sharing your screen. But what exactly are you trying to show?
I've not showed anything in the story.
Yes, now we have.
Now we are able to see.
Yeah, rules of storytelling. Yeah.
Storytelling. Yeah.
Yeah, but were you able to hear me? The story?
Yeah.
So I just want to know, everyone may not have to type here. I just want to know what should be the farmer's choice, to have an enemy next to him as a neighbor, or a friend?
A friend.
Friend, but he's been attacked by untrained, professional dogs. Like, he's been attacked every time. He has to take some actions, right? And he's gone to judge all the way. It means that his all efforts of communication is failed. So what should he do?
Two things here. My observation that okay, having untrained dogs or them causing a problem is still a problem, but having an enemy as a neighbor is much bigger a problem than having untrained dogs.
Yeah.
One. Two is that the second thing is that maybe if you the story doesn't tell us in and out about the friendship or the equations between them, but maybe considering they're not.
No, I'm still at half of the story where I'm asking, what should farmer answer to the judge? Should he answer for a friend or a foe? He should say whatever it is, I don't bother. Or he should say, I really need a friend. Is there a solution? What should he go for?
I think, you're right. Maybe I would say, Judge sir, maybe you're right in your thinking. What should be the alternative solution?
Yeah.
Why don't you suggest me?
Yeah. So, all right. Then the farmer replied, I really need a friend as my neighbor. I don't need an enemy. And the judge says, all right, I will offer you a solution that keeps your lamb safe and which will keep your neighbor also as a friend. So farmer is excited. Is there a solution like that? So he agrees for whatever judge gives him a solution, and farmer goes home back. And he wants to try this suggestion as fast as possible. So he's at home. So can anyone think about what may be the judge's suggestion here? Is there a possibility to have a suggestion like that? And can you think of any situations like what may be the... Okay. So he cannot waste time now because he has already got judgment from the judge. So he wants to try. He took 3 best of his lambs and presented them to neighbors, 3 small sons who were beside themselves with joy, and they began to play with them. To protect his son's newly acquired playthings, the hunter built a strong kennel for his dogs. Since then, the dogs never bothered farmer, and out of gratitude, this hunter always gave farmer whatever he hunted as a gift. And with that, the farmer always reciprocated with cheese what he made. So within a short time, neighbors became good friends and they started living maybe in a very civic way. So in a short, if I have to narrate, so there is a Chinese proverb for it, like one can win over and influence people the best with gestures of kindness and compassion. You don't need to make it too complicated. He would have spent so much money fighting those battles, judges' money. 3 lambs may cost him money, but he would have lost a lot. Like everyone have experienced that. Whoever goes to lawyer, both are losers here, both the parties. So one more American way of saying it is one catches more flies with honey than in vinegar. So that's one more moral we can take. So it may be a simple story like which sets up, and if I can show you the intention here is everything, whatever we narrate, should have some purpose, and it should make people think, because we are using the story. If you can see, I'm okay. Can you see my screen now?
Yeah, now you have moved on to SlideShare. That's good. Yeah.
Yeah. So when we talk about story, it is like narrative. A very simple way of telling what is a story is like narrative account of real imagined or imagined events. But when you ask a storyteller community, then they will say that they should have a proper narrative style. Everyone can be a good storyteller. I was not one here. I hurried up for the time, but still we can use a lot of voice modulations, things like that. We can be a good actor on stage when we are narrating, and it is possible. And we can explain complex things like very complex rules of some game or something with a story where it has more impact. And I cannot see my own slide. Okay, there are 4 P's of storytelling. As I was mentioning, like ancient China or anything, it's like people, place. People means not only characters in the play, it may be animals, it may be anything which you consider is a subject matter. And there should be a plot and there should be a purpose. It's a very common 4 P's which I mentioned. If you want to narrate something extra complex, then you can involve more senses to it and things like that. How do you obtain? You can exchange stories or listen from nowadays we have a lot of online materials, and then we can make our own stories by writing the life experiences and media, things like that. So here, when we are using it as a trainer, the adult learning theory always explains there should be an interaction, there should be independence of audiences here, and then experience-based learning. This is what is adult learning theory thrives on. And how to link this between adult learning and storytelling. It may be the simplest story, but to have an effect on adult to remember, we need to little bit modify and add others' experience into this. That is a main subject of consideration when you're teaching adults as a trainer through storytelling. Learners, like when you say that it is believable, because when you are using story, and it should be rememberable and entertaining. Yes, at certain stages we can go ahead by entertaining using voice modulation or including interesting part of our story as a building up curiosity or adding more if we had more time. And it should always empower the adult learners. Like he should have something to contribute there and recognize the value of their own experiences in the story we are narrating. That is the important thing. Knowledge sharing with their personalized experience. Okay, I should have solved my neighbor's problem with such a simple thing. That thought should come in a way when I told today's story. Like if we are not adding our own experiences in adult learning theory, it doesn't make sense for the learners. Usually they don't connect much. So it should always inspire for personal growth when we are using as a trainer, and which will make, so there is a methodological approach when we are wanting to include. At the end of this, I will be placing one of the story complete way how it can be conducted in your workshops, all reflective questions and things like that related to healthcare. But this is how it should be planned. Like you need to have a warm-up session, technical session, activities, then activity like you may practice it with telling stories and then listening to the story of others, and then how to conclude it. Are you able to grab some message in that and making the verbal imagination of what they are communicating to you? If that could be achieved, then only we can consider as a stories, and we we can start narrating our life stories, also making them categories, like it can go for a motivational, it can go for entertaining, and it can this story can convey this message. Like that we can start establishing wherever we hear some stories, where we have to place them and how should we recollect them to tell it to the audience. That is important. So usually whenever we are telling story, they say that it makes some hormones to release more. So like if you say Angel's cocktail, dopamine, oxytocin are mainly the one we want to concentrate, and endomorphins also. And in this, it actually, a lot of people, if you Google it, you will come to know like how a story can create focus, motivation, and memory. So the main thing is even a suspense, like how you watch a movie, it can be created by storytelling, so that audiences release these hormones, which will help you to communicate that message to the audiences, and make their learning process more effective. And same this is the method, and same way when we are communicating a stronger stories with more of adrenaline and cortisol in it, it's a very different impact it can cause to the audiences, and you can bring out some intolerant, irritable material under them, and they may go for a strike. It's about how we narrate and how we evoke their emotions, and what is our intention of storytelling to evoke what. So it is very powerful tool to make it the experiences go in any direction we want to take it to. So coming to the last 3 minutes, like from like so many years we are if you go and narrate and think like how the language was formed and things like that, we have a correct history of knowing that 100,000 years back they started communicating in language, and once they started learning and they started passing the stories to others, that is the only way to communicate in the earlier. Then 27,000 years back they went on making some pictures which could communicate the messages, and started storing the information in this way. And 3,500 years back, that is when we could see the literature coming in and we could read, write, or something like that. It started maybe. And if you see PowerPoint presentation, it's more than like maybe 12 years or 13 years old way of communicating. So if we concentrate all our energies on PPTs, we are losing 1,000 odd year old way of learning. So I think storytelling is very simple, very effective, and can be practiced by anyone. So rather than telling advantages and disadvantages about this, there are no disadvantages if you have a purpose of why you want to tell a story. Even simple narration of Dr. Indu telling that how her dressing made her feel that she didn't give importance to what should be shown. So that itself conveys a lot of connect as humans, and the story gets to reach to the correct position of the heart where it should reach. So I feel she's very effective. Her all narration shows as a story only every day. So I don't have to prove much on the storytelling. And thank you very much for everything.
Thank you, Dr. Shaktikala. I think you did a wonderful job by talking about storytelling, and you could actually create interest. I think one benefit of the storytelling was when you started asking us to find answers. I think that's where our critical and creative thinking was really, evoked. We had to think and look for answers. If we were in that position or role, how would have we done it? If you can stop sharing, then we can all see each other for the last 1 minute before we close the session. I think that's another important tool to go about, spreading your message. Some people are really good at it. We have to learn it. I think the art of storytelling has to be learned. I myself personally looking for a formal training in storytelling, because I have seen that when I talk about any story, it really leaves me happy and it leaves my audience very happy. And I'm able to convey a lot of important, difficult messages in a very simple and effective way. that story of, three laborers working on a building. I hope you remember the story that I shared with all of you, where one said that I'm just earning my livelihood. The second said that I'm frustrated with this. And third said I'm constructing a huge temple, beautiful temple. I learned it somewhere. I learned it for a different purpose. But whenever I try to, connect it with the importance of positive attitude, my job of explaining positive attitude is done. Otherwise, I can't explain what is the importance of positive attitude. One job done by three people with different attitude. The outcome is different. So I think each one of us must master the art of storytelling. If anybody comes across any program online or offline on storytelling, I would love to be part of it. Especially we have a couple of trainers who are formally trained as trainers. So they maybe you all know, if you can find us something like this, that will be really interesting. But thank you, Dr. Shashikala. I think you did a wonderful job by talking about storytelling. Your story was also very interesting, very new. That's the thing, you have to really keep looking for new stories, because you can't repeat the old stories. And every day we have heard it. In the moment they say you have heard it, we have heard it, you lose the interest of telling them. So you have to be really good at, digging new stories. And WhatsApp is full of stories. WhatsApp is full of stories, yeah. So with this, we come to the end of this session. Any questions about whatever we have discussed? Although I know we are exactly 10:30. So I wanted to finish. Yeah, I want this to be. So if no more questions, we close the session today. Thank you so much, everyone. Let's meet next week at 8:30 instead of 8 o'clock.
Thank you, ma'am.
Thank you.
Thank you.